Darlene.
Darlene will be my co-intern.
Yep. And Moses will be one of your upper levels. Joanne is going to be one of our discussants today, but as always, we'll ask someone else to join and talk about a case with us. And if anyone has a case that they're able to present, of course, we need that too. So please shout out in the chat if you've got a case, and if you would like to join me and Joanne in discussing. Steph today unfortunately wasn't able to join. She did not gain permission from our 6-week-old baby on this given day. While we wait, I'll just share a couple of reflections from rounds earlier. Joanne and I are working with a couple of really phenomenal upper level residents that it's just been really fun to watch in action and kind of observe and learn from. And there are two things that I just pointed out that they did so well while talking to patients that I just kind of want to share with that, just because I always think these kind of interpersonal and communication skills, especially with patients, are at least half the battle in helping them to feel better and live longer, because we can always know exactly what's going on and what needs to be done, but if we can't help the patient to also understand those things and be on board with the treatment, then it often doesn't help all that much. So one of the things that Jen, one of the residents, did was just doing so well is just leading the conversation with the patient in very open and kind of like non-leading language. And I was saying how we all learned to try to use open-ended questions like at the beginning of when we're taking the history. But I noticed that she was also using open-ended questions when basically like talking about the plan, or sort of, and it was almost like a very informal teach back. Instead of saying like, just the example that comes to mind is, instead of saying like, is your sister going to pick you up today? She said, and how are you going to get home today? Even though she knew that, as of the last kind of rumors, that was the plan, that the patient's sister was going to come grab him. But this was a patient with some cognitive impairments, and it was just such a good opportunity basically to see if the patient was aware of that plan, and to potentially reinforce the patient's understanding and memory of that plan by having them recall the answer as opposed to being given it, which obviously we have learned as educators is an effective technique when we're all trying to learn as well. So that was really good. And then the other thing one of the other residents just did with the last patient that we saw was, she was kind of asking some questions and talking about stuff, and the patient just didn't look like they were fully engaged in the conversation. And she just interrupted herself mid-sentence and said, Mr. X, like you look a little uncomfortable. How are you feeling? What's going on? And I think that's just so important to recognize when a patient is feeling a feeling, right? Whether that's physical or emotional, to either just open-endedly inquire about it, or sometimes to incorporate validation and to try to name the feeling and then inquire further about what might be behind it, or at least name your observation, and to address whatever might be on people's minds when they're clearly not in a place to be talking about what's on your mind. So I just thought that was really nice, right, Joanne? And again, I always think it's so important to continue to observe and learn and grow and self-reflect about these skills at the bedside, because they're just as important as our diagnostic guruism that we're trying to achieve.
Yeah, and also the case where when a patient is having new symptoms, I also learned from you, instead of asking, is this new, which could have many different implications, to ask them directly, when did this start?
Thanks. Cool. So where are we, friends? Rafael, I will make you co-host, just a second. But would anyone else like to join me and Joanne in discussing the case? And then do we have a case yet?
No case yet. I think Gabrielle volunteered to discuss.
Awesome. Thank you, Gabriel. And no case yet. Travis or Rafael, do you guys have a human DX case in your back pocket by any chance?
Already? Sure, but meanwhile, maybe Gabriel can introduce himself. Maybe can encourage someone else, I don't know, to present a case.
Okay, awesome.
Hi, everyone. My name is Gabriel. I'm from Lima, Peru. Very excited to be here today with you guys. I love the VMR community. And come on, guys, I encourage you to present a case. It hasn't been to be very elaborated. The important thing is the discussion and the path to the final diagnosis.
Thanks, Gabriel. And Joanne, I guess I introduced you, but anything you want to share with our friends about what you like to do outside of work, or what you enjoy?
Oh, lots of things. Here in Houston, actually, I love the rodeo. If you guys ever get to come here, the Southern food, the fried Oreos is something that I really learned coming from Seattle originally. But otherwise, I like to play the violin. I play with the Texas Medical Center Orchestra. Here in the TMC is actually a huge community of healthcare providers, like 109,000, almost like a city is the latest stat I heard. So it's really fun being able to organize a musical orchestra with them. And
cool.
So yeah.
Have you ever played with Dr. Musher?
I have. He was our concert master.
So one of our like kind of master clinician infectious disease doctors here is also part of the TMC orchestra. So that's really special to have played with him. Okay, so looks like we might just go with Rafael, your case, and whenever you're ready, you can share the screen and start telling us about your patient.
So I think Travis is describing today. Are you friend?
Yes, sir.
So when you start sharing, I will start the case. So to begin with, this is a 48-year-old woman with rapidly progressive ulcers on hands. And maybe it's a good place to stop.
Okay, Gabriel, why don't you kick us off and just share your thoughts about this chief concern?
Well, so yes, very familiarized with dermatology yet because I haven't got any dermatology rotation. But when I hear ulcers on her hands in a 48-year-old female, I'm thinking about autoimmune diseases because it's a typical age when it can debut. Like, for example, not classically ulcers, but for example, there is something called mechanic hands that can present in anti-synthesized disease, and it can be like a kind of myopathy, inflammatory myopathy. I'm also thinking if this could be erythema multiforme major that can present as ulcers. I've seen photographs not in the hands, but in the knees. Another thing that comes to mind is infectious diseases, like, for example, syphilis, herpes that can present as erythema multiforme major. But yeah, I would like to get information about the background of the patient, if it's just the ulcers, if there's other symptoms that could help us to unify a diagnosis or searching for a pivot point or a clue. I would also like to know about the medications she's using, if there's, like, for example, also autoimmune background of the patient, or if she's feeling like, for example, signs of anemia. Sometimes autoimmune hemolytic anemia can present as distal necrosis, and that distal necrosis can transform in ulcers. So yeah, I think ulcers are very non-specific, but trying to say a little about it.
Thank you, Gabriel. Yeah, I think it's, upper extremity ulcers are hard to have a very isolated upper extremity ulcers, hard to have a very good kind of framework for. And I don't have one off the top of my head because they're just not very common. I actually don't know if I've ever seen a patient with this kind of primary symptom, right? Lower extremity ulcers are very common, and oftentimes they're associated with some kind of vascular disease, either venous stasis, venous hypertension causing the abnormality, or arterial insufficiency, or neuropathy from diabetic disease or other disease that causes injury and then abnormalities and healing. And but to have isolated upper extremity ulcers, I agree, is a little bit harder to approach. And I'm totally with you that it's hard not to suddenly think of some kind of autoinflammatory state, and perhaps with a different mechanism of vascular abnormality, or else to really think of this as a primary dermatologic disease, right? And to think about infectious or autoinflammatory processes that cause a breakdown of the skin. And I think it's going to be really helpful to have a little bit more framing of the case in terms of the background, as well as to be able to see a description and some more details about what the ulcers are like. So with that, Rafael, tell us a little bit more.
Okay, so this is a patient that presents with rapidly progressive painful ulcers on both hands, and 12 days ago, she noted a red, irritated patch of skin between her right thumb and forefinger, which she thought was from sweeping. The following day, the area became raised and opened to form an ulcer. This patient also had an isolated fever to 101 Fahrenheit, which resolved with acetaminophen, and she also had episodes of diaphoresis. This patient was seen in the ED and diagnosed with a spider bite and discharged with clindamycin. When it comes to past medical history, this patient has chronic sinusitis and cervical spine degenerative joint disease. And the only medication that she took was acetaminophen. And additional HPI to help you guys, her right hand did not improve with antibiotics. And 8 days after the right hand ulceration, she noticed a purple papule near the PIP joint of her left index finger. The next day, this became swollen, tender, and red, and ulcerated. This patient also reports several months of intermittent pain and swelling of MCP, PIP, and DIP joints on both hands. This patient also refers unintentional 10-pound weight loss over the last 3 weeks. She also denies diarrhea or history of IBD. Social history. This patient lives with children and grandchildren in a rural area in the Central Valley area of California. And she works in an elementary school. Has a kitten at home, and she does yard work and gardening, but does not recall a spider bite. This patient also denies smoking or drug use, and she refers occasional alcohol. And that's the end of aliquot number 2.
Thanks, Stefan. So, Joanne, we just got a whole lot more information, right? And I can maybe follow up with some specific questions, but just based on what we see now, what do you think about any or all of it?
So it was very interesting when you mentioned that it's painful. I think that kind of narrows down the differential in some ways, because there are painful rashes and others that aren't. I know earlier we talked about syphilis, which in that case is just one example where it's typically painless ulcers. But what is also interesting here, so she has a fever and diaphoresis, and she also noticed a papular rash along different joints. And initially, actually, when I was hearing about this, one thought that came to mind is her exposure. And here you mentioned yard work and garden work, and given kind of the longitudinal pattern of the ulcers, I mean, one possibility we're thinking about is probably sporothrix. I think those usually present initially with papules that could ulcerate. So that's one thought. But kind of on the flip side too, now we're hearing more systemic symptoms, which is making me think a little bit more about other kind of broader causes. I'm not quite sure if she's immunocompromised in this case, but she lives in the Central Valley of California, and there's some opportunistic fungal infections that we could potentially think of as well that could present with cutaneous findings.
Like you mentioned Coxie when we were muted. Yeah. Cool. What do you think about the this like more kind of background history of a few months of pain in her knuckles, basically, right? Of both hands, as well as some weight loss, and yeah, does that like, could that be incidental, or can you think of a way that that would tie in with what's going on now?
It's a great point. In that case, more of a systemic cause. I mean, autoimmune is something we discussed earlier. Let's see, she has joint pain and fevers, so that's one possibility. We covered infections, although I would expect an infection to be more acute instead of something that's brewing for so long with just these symptoms. Other categories?
Yeah, well, I think it depends on the infection, and some of the ones that you mentioned, like, you know, I think of dimorphic kind of endemic fungal infections, your cocces and your histos and your blastos, and your paracocces in different parts of the world. You know, a lot of those can have acute presentations, right? The most common, you know, syndrome of coccidioidomycosis is like it's like an atypical self-limited pneumonic illness, right? At least in immunocompetent persons. But cocci, as well as, again, a lot of its brothers in different regions, can really present as kind of chronic, almost tuberculosis mimicking infections, whether those are, you know, in the lung or in their disseminated form,
Right.
or just like TB, they can almost do anything, where they can, you know, present with mass-like lesions and mimic malignancy, and a lot of them can be associated with just kind of like non-specific systemic inflammatory symptoms that patients almost can kind of get used to or forget about, or, you know, like will only tell you if you specifically ask them, and kind of that's the hint to just the chronicity of it. But I think, you know, it's such a good kind of setup, right? When you hear someone who gardens, and then, you know, you know, just the history that it started with, it sounded like she was sweeping and she thought it was just a friction ulcer between the thumb and first finger, if I heard correctly. I mean, that's a pretty compelling history, right? And I think the other possibility is that maybe she's had an autoinflammatory condition in the background, and that's like the joint stuff. And now on top of that, she has a new process, and that new process could still be potentially infectious.
Right.
Or some of these chronic autoimmune disorders are also associated with autoinflammatory dermatoses that we could be dealing with here. So and that compelling history of the patient saying it started after I, like was sweeping a lot, and that's the area that I thought it was just like a blister from friction, and then it kind of progressed from there. So things like pyoderma gangrenosum, which is one of the neutrophilic dermatoses that can be associated with inflammatory bowel disease, with rheumatoid arthritis, with certain malignancies and stuff, are often triggered by cutaneous trauma, right? Yeah, and they're worsened oftentimes by continued manipulation, or if you try to biopsy it. What's that called? There's a term for that, I think. Kebner, thank you, Kebner phenomenon. So I think we could be dealing with something like that here, and oftentimes they can also be associated with systemic, kind of acute systemic inflammation and fever and stuff, and make people worry about infection.
I also just noticed she has a kitten at home.
Okay.
In case if we're thinking about animal exposure, Bartonella in this case, if she's had a history of being scratched,
yes,
could be something to consider.
Absolutely. I don't know if anyone knows, I'm sure someone knows, actually we saw Kushal on the chat, so maybe he can tell us, like, how often does this primary kind of Bartonellosis present more with like cutaneous ulcerating disease? I think of it as, that's the portal of entry, but then the predominant kind of clinical syndrome is the lymphadenopathy and swelling. But maybe we can look in a chat and see if anyone can help us with that. But I think, Joanne, you built on a great discussion from Gabriel, and maybe we can actually kind of get a little bit more description of what this looks like, and let Rafael kind of continue to unfold the case for us.
Yes, Steven, I would like to add a little thing. I think it's very interesting that you mentioned TB, because actually here in Peru we're very fans of TB, and one syndrome that can cause TB is Ponset syndrome, that can manifest as asymmetrical joint pain that mimics a lot of rheumatoid arthritis. And there's patients here in Peru that are diagnosed with rheumatoid arthritis, and then they are diagnosed as Ponset syndrome caused by TB. So there's a thing we should keep in mind, because the cutaneous manifestations of TB are very broad, but considering the patient is from the United States, TB is a very rare disease there. So I will think more about the autoimmune diseases, like as you said. But yeah, it's very interesting the kitten at home, because Bartonella henselae can cause leukocytoclastic vasculitis and also ulcers. In fact, Bartonella henselae is like another TB, can cause a lot of manifestations. So
those are fantastic points. Thank you, Gabriel, for adding. I don't think I've ever heard of that syndrome of TB. Can you spell it in the chat? We can wait for that. And Ponset syndrome. Okay, there we go. Thank you so much, Gabriel. All right, Rafael, take us forward, please.
Okay, so the physical exam. The temperature is 36.9, heart rate 62, respiratory rate 18, blood pressure 120/75, and she's saturating 99% in room air. Generally speaking, this patient is non-toxic appearing, and she also appears older than stated age. Her HEENT, cardiac and pulmonary and abdominal exam are all unremarkable. When it comes to the right hand, there is a swelling of the dorsal surface, tenderness palpation on the second and fourth MCP joints without erythema or swelling, no streaking, tracking up wrist or arm. On the left hand, there is tenderness to palpation of the first to the third MCP joints without erythema or swelling. and also no streaking tracking up wrist or arm. All the other joints with no abnormalities. And her right hand also has an open ulceration with friable tissue between thumb and index finger. And the left hand, there is an open ulceration with friable tissue over the second PIP joint. And there are some images of the ulcers that I can show you guys. Can you see it? Then, can you see it?
Yes, we can see it.
Okay.
Wait, I couldn't see it. Did you project the photo or?
No, I'm showing you on my camera.
Oh, I see, I see. Let me see.
Is it focusing?
Okay, yes, a little bit.
Oh my God. So the other hand is like this.
Thank you. Gabriel, what do you think?
Yes, wow. So there's almost nothing remarkable on the physical exam but the ulcers. And I think the utility of that will be that, for example, we were thinking about some types of vasculitis, and the vasculitis can also present with pulmonary abnormalities, or for example, paresthesias, mononeuritis, but we don't see that on the physical exam. So I will be like, I think this could be less likely as systemic vasculitis. Like, for example, I was thinking about Wegener because of the sinusitis, but I can see any pulmonary abnormalities. I won't rule out it yet, but I will consider more another etiologies. The ulcer, I think it was very interesting because of the fact that it's not the ulcer, like, for example, of elevated borders that you will expect, for example, in leishmaniasis. I think this will be very unlikely given the epidemiology of the patient because it's from the United States, but just for adding up. And it's just one ulcer. The photos that I've seen about sporothrix, because I've done a rotation with Valeria of cutaneous leishmaniasis and sporothrix, have like a lymphatic pattern. Like, for example, you have a ulcer and then another ulcer, and you can see like a lymphatic pattern. But I just see isolated ulcer in the hand. But given that like the patient does garden work, I don't see like, I can't rule out yet because I don't know if sporothrix can present as an isolated ulcer. But yeah, the social history is very important to me. I'm thinking about any kind of random fungi that is causing the ulcer. Or the other interesting thing is the tenderness of palpation in the joints. That would lead me more. Okay, so the tenderness of palpation that we're dealing with arthritis. So I think with arthritis and the ulcer, like I'm thinking more of an autoimmune disorder. But yeah, I'm kind of like lost in this process because I think this is a hard case for me.
I can't imagine why this case would challenge anyone. Joking, of course. Gabriel, your knowledge of infectious diseases and everything else is always amazing. I don't have too much to add, honestly, to what you said. Sorry if I missed this, but have we commented on the history of chronic sinusitis yet?
Not yet.
Not yet. Does that ring any bells, Joanne, when you're dealing with something weird going on that you can't explain and the patient has a history of chronic sinusitis?
One of those autoimmune conditions, I'm trying to think, affects, I'm trying to think which one it was. Was it Wechner's that affects not only the pulmonary system, but also the nasal lining? As well?
Absolutely. So granulomatosis with polyangiitis, which is one of the ANCA, typically ANCA positive small vessel vasculitides. That it's really it's a systemic disease, right? That tends to affect some organ systems more than others, and most commonly involves the lungs, the upper respiratory tract, which by the way includes the ears as well, commonly as part of that continuum. But commonly causes glomerulonephritis, right? Very commonly affects the eyes and really can affect almost any organ. Now, the cutaneous manifestations of GPA tend to be more the typical small vessel vasculitis of the skin, which is more petechiae, microhemorrhages, right, which are more common in the dependent lower extremities, although can happen other places. But a lot of these classifications of vasculitis by vessel size are kind of like artificial cutoffs, right? And sometimes there can be overlap of the size of blood vessel that's affected with these vasculitides. And the reason it becomes kind of relevant here is that when the size of the blood vessels, arterioles that are affected, go from being like the smallest kind of vessels to more medium size. So for medium vessel vasculitides, the cutaneous manifestation actually tends to be more like nodules and ulcers. So if there is some overlap of kind of the size of vessel that's affected, you could have somewhat more atypical kind of rashes that could still be vasculitic and could fit with this picture. So chronic sinusitis not from GPA is common enough. This could just be, like an accident or a coincidence or whatever. But it certainly, I feel like should raise an eyebrow and make you at least consider the diagnosis a little bit more strongly. So with that, I think anytime you generate hypotheses from your history, from your exam, from whatever, right? Diagnosis is a very iterative process where the hypotheses you generate from the information you have inform the further information you seek. So, and the categories of information you continue to iteratively seek could be more history questions, right? You could ask the patient about, more closely about pulmonary symptoms, about urinary symptoms, ocular symptoms. It could be closer examination of certain parts of the body, or it could be, certain laboratories and imaging. So anytime you suspect vasculitis, you want to look at the urine, you want to look at the lungs, and you want to try to fit additional pieces of that together. And this is all, again, I'm only talking mostly about GPA is because Gabriel covered the infectious possibilities, I think, better than I could have. So that sort of stands very much for itself. Rafael, you want to tell us more?
Sure. Now the labs. Her white blood count was 6.1. Her hemoglobin was 10.1. And her hematocrit, was 31.3. And her MCV was 92.4. And her platelets were 518,000. The basic metabolic panel was unremarkable. And her ALT was 26. ALT 24. Her OCFOS were 126. Total bilirubin 0.6. And total protein 7. Iron studies were made and they showed total iron 25, which is normal. The TIBC was 311, which is also normal. And the transferrin saturation was 80%, which is low. And the ferritin was 130, which is high. Additional labs, her HIV was negative. Her blood cultures were also negative. Her ESR was 39. And her CRP was 4.8. Her ANA was negative. Rheumatoid factor also negative. And her seroprotein immunofixation electrophoresis showed no abnormalities. And I have two more pieces of information before the final diagnosis.
Rafael, is it two more pieces of information or two more aliquots? Like
two more aliquots I can combine into one because they're really straightforward, you know.
Okay. All right, Joanne, what do you think about these basic labs? Do they help us at all?
So white blood count is actually normal. I mean, it's not anything remarkable. She is slightly anemic, but I probably wouldn't think too much of it at this point. Platelets are elevated slightly, but it could be a reactive process.
And can I ask, why don't you think too much of the anemia? Expand on that a little bit.
I mean, it's borderline anemic, and her MCV in this case is unremarkable. I'm just thinking, she's 48 years old. She's not microcytic. I mean, that's one thing we'd always think about if someone's anemic and could be bleeding somewhere. Another kind of category of anemia to think about is anemia of chronic disease. But in this case, her progression, her symptoms have been going on, it seems like, for almost 2 weeks, in a few months. So, I mean, it could be starting, like the start of a process, or
yeah, completely agree. Okay, what else?
I'm looking through here. Iron is normal. HIV is negative, which is helpful to know, because if she's immunocompromised, that would put us in a different context of thinking about opportunistic infections. Let's see. ESR and CRP are slightly elevated, so that could point both towards infection, or vasculitis could also lead to that. So it doesn't really help us narrow down on things, but something is going on for sure. And ANA and RF is helpful to know that they're negative in this case.
Yeah, I think if I agree with everything you said, that was all spot on. If the ANA was strongly positive, right, or if the RF was positive, I feel like those would be more like stronger pivot points. Whereas when they're negative, they make some conditions a lot less likely, right? Like if your ANA is negative, you pretty much don't have lupus, right? But for most other autoinflammatory conditions, you don't necessarily, they're not necessarily either specific nor sensitive, so it doesn't move the needle too much. I have this feeling that like the right infectious disease doctor or primary care doctor who practices in the right setting and sees the right patients, like there's a chance that they hear the story, they look at this rash and they're like, oh, this is classic blank, right? So we'll see if we learn that lesson here. The other category of things we haven't really brought up is just like the primary kind of blistering autoimmune dermatologic diseases.
Oh, good point.
Right, like
pemphigus
or pemphigoid. Yep. How are those on the scripts of yours compared with the presentation here?
Yeah, my impression is pemphigoid. It affects. It's like the antibodies between the cells. So in those cases, you usually get really tense blisters before they ulcerate. We don't really have a story of blister formation prior to the ulceration, so less likely based on that. Pemphigoid is actually more similar if I were to compare it to these cases, because you have sloughing of the skin. And there's like the term for, it's like
Nikolsky sign.
Which could be possible. But one thing I would say is usually those are more distributed throughout the body. And in this case, it's really limited to the hands, which is an interesting distribution if we're thinking about.
Yeah, completely agree. And on the one hand, you could say, Nikolsky sign is basically that friability where the dermis and epidermis are loose, right? So when you push on a blister or kind of pull on the skin, it sort of like pulls away, right, or expands. So, but if you imagine like an earlier state of that disease, right, like before you overtly ulcerate on your own, basically whatever friction she may have started was basically like hardcore Nikolskying, yet subclinically sick skin, right? And you can imagine that an ulcer may start with that. But I also don't think of the distribution of those that like typically involving the hands, where the skin a lot of times is actually like thicker, right, and more and less prone to potentially to have this happen. And then there's the epidemiology of kind of who tends to get these conditions and stuff. And for those conditions, typically, if you have fever, generally it's from superinfection of the skin breakdown rather from the degree of systemic inflammation. So I think that's why none of us have kind of like gone in that direction very strongly. But I think just talking about, blistering, ulcerating skin disease, it may be worth just quickly reviewing. Gabriel, anything to add?
Yeah, awesome discussion, guys. Actually, not much. I'm thinking somehow just crossed to my mind. This could be psoriasis, because psoriasis can have a lot of atypical presentations. I truly don't know, because of its psoriasis is also like a chronic inflammatory disease, and that could explain the inflammatory anemia that we've seen, and also the mild elevation of the inflammatory markers. But yeah, I think I would like to remark what you said about the ANA, that lupus can present as ulcers, but it's very sensitive for it. In case of the rheumatoid factor, it could be like less likely to be rheumatoid arthritis, but we are dealing with a very atypical presentation. So right now, if I were in real life and I'm seeing this patient, I will get a biopsy of the lesion, consult with the dermatology team, and also asking for myositis-specific antibodies. Maybe this could be like, for example, an anti-synthesized syndrome or mixed connective tissue disease. But yeah, it's like very hard.
Absolutely. Thank you, Gabriel. Okay, Rafael, what do we have?
Okay, just one more piece of information before revealing the diagnosis. So additional labs, this patient had anti-hepatitis C antibody positive, and her HCV viral load was actually 1.3 million. Does it ring any bell?
What do you think, Joanne?
Cryoglobulinemia would be something to consider here. And it fits with the joint pain that she's been having.
Wow.
Oh yeah, I
that's
agree.
What's that, Gabriel?
I agree.
Yeah, that definitely kind of strengthens the case for vasculitis and offers a mechanism sort of of vasculitis. And in a morning report kind of case presentation setting, it's a lot easier to think that since this is the piece of information that we see next, right, this must be and can only be the only outcome, depending on the patient and sort of the incidence of hepatitis C in a given population. You may or may not find that there's an association with whatever else is going on now. But in this case, certainly with us kind of worrying about vasculitis so highly, and we didn't go through kind of the all of the different vasculitides, right? We kind of alluded to a couple of them: rheumatoid vasculitis associated with lupus, or ANCA associated vasculitis, but certainly on that list is cryoglobulinemic vasculitis. And it does tie things together with the joints and, and the cutaneous lesions. So interesting. Any other thoughts, Joanne, Gabriel? Or should we go home from this? Are you ready to put your money down and say these are the cryos are going to be popular?
This is a
Yeah.
good learning point for me too, because between the fingers, between the thumb and index fingers, that's not a place I usually associate with these vasculitides. I wonder, like, what are the more common places you see skin lesions located at?
I'll answer that question in a second, but Gabriel, you were about to say something too?
Already not much. I agree a lot. Like, for example, it's a very refreshing thing for me to remember that hepatitis C could be present with cryo and these cutaneous manifestations. I didn't have that in my differential diagnosis. So yeah, always learning.
Yeah. No, same. And so I probably would be ready to put my money down and say, like, the mostly likely condition here is going to be HCV associated cryoglobulinemia. But Joanne, I think, to answer your question, I don't think like the sweeping was an accident, right? And because we've all done something with like a long stick or like rowing or whatever, right?
Yeah.
Like, this is just such a typical area that it's the skin is very thin, right? And when you have something here that's constantly going back and forth, like, so if you just imagine, blood vessel being compromised, blood supply being compromised, like that's the mechanism of, a lot of vasculitic complications, right? If you imagine the capillaries and the small vessels being more fragile, that's what, because they're inflamed. And it's just not hard to then take the next step and say, if you start off with skin like that, right, and you traumatize it and you stress it, right, that's where the skin manifestation is going to be first, or that's where it's going to be worst. So I think I don't think it's the super typical place to start with, these vasculitic skin lesions, but depending on what you're doing with your body and your skin and your hands, I think it could still make a lot of sense.
It's a really great thought.
Do you guys see a lot of hepatitis C cases? Here in Peru is very rare disease. We have hepatitis B.
There is a lot of hepatitis C here. So I work in Houston, and I work at the VA in part. That's where we are now. And a lot of veterans have hepatitis C that they may have contracted, during their service. Back in the 60s, 70s, it wasn't called hepatitis C. It was called non-A, non-B viral hepatitis, because the actual viral pathogen wasn't discovered yet. And if you don't know what something is, you can't test for it, right? So it actually wasn't part of the routine kind of precautions of checking blood for blood transfusions. So a lot of veterans got hepatitis C from, blood transfusions they had when they had a physical injury, or when they had a surgery for appendicitis, or who knows what else. There are also high rates of, there were high rates of use in the military of IV of injected drugs, and some folks contracted it that way. In some parts of the country of the US where rates of intravenous drug use are very high, for example, in Charleston, Massachusetts, the rate of hepatitis C positivity among patients who inject drugs is more than 90%. So HCV is still very common in the US. Thankfully, we have been seeing and will continue to see fewer and fewer complications of hepatitis C as the new antiviral drugs become more available, because they're incredibly effective. So it's more and more common in our medical records to read, past medical history of like hepatitis C status post, antiviral therapy with complete response. So yeah. Okay, Rafael, do you want to teach us about this case, and then we can hear the summary points?
Okay, so incredible discussion about cryo, but the skin biopsy actually showed a dense dermal neutrophilic infiltrate with leukocytoclasis. I'm sorry if I'm not speaking that right, and marked papillary dermal edema. And this was consistent with Sweet syndrome. And the correct answer is actually neutrophilic dermatosis of the dorsal hands. Let me check the teaching points. So she was diagnosed with neutrophilic dermatosis of the dorsal hands, which is a neutrophilic dermatosis that can be a localized variant of Sweet syndrome. It's likely an atypical presentation of pyoderma gangrenosum. And she was started on prednisone, which was tapered over several weeks with significant clinical improvement of both hand lesions. And evaluation for underlying infection or hematologic malignancies revealed positive serology for HCV, and she was referred to GI clinic and was treated with legispavir, sofosbuvir, for 12 weeks for genotype 1A hepatitis C. And there's this pearl that I really liked, that other skin diseases associated with hepatitis C include cutaneous necrotizing vasculitis, cryo, porphyria cutaneous tarda, and lesion planus.
Wow. Amazing case. So Rafael, just repeating that last part. So there's a different phenotype of vasculitis associated with HCV that's not cryo. What did you say? Cutaneous necrotizing vasculitis?
It was cutaneous necrotizing vasculitis, mixed cryo, porphyria cutaneous tarda, and lesion planus. All of them can be associated with hepatitis C.
Thank you very much. Okay, who's going to take us through just the summary points?
It's actually me.
He's a machine.
I'm multitasking in our language, so I'm sorry if I say something wrong. So this is patients with rapidly progressive ulcers, and we thought about many etiologies, including autoimmune diseases like dermatomyositis, rheumatoid arthritis, IBD, and SLE, infections like syphilis, herpes, and also primary dermatologic diseases like pemphigus, and metabolic causes like PCT. And then Zaven reminded that it's actually more common in the lower extremity, and we can think about venous stasis, venous hypertension, arterial insufficiency, and also diabetes neuropathy. And then we talked about sporotharcosis, which is related to gardening that we saw in this patient, because the spores are introduced in the skin typically by a thorn, and there's a local pustule or ulcer with nodules along draining lymphatics. And then, since this patient was from California, we thought about also coccidioidomycosis, because it also has skin manifestations and systemic symptoms, and it can disseminate to the skin and to the bone, leading to erythema nodosa or multiforme, and could cause also arthralgias. And it's actually known as desert rheumatism. And there's this pill that this endemic mycosis cannot be transmitted to person, unlike TB. And then Gabriel reminded us to think about cutaneous leishmaniasis, even though it was not very likely since this patient was from California. Just a little bit of a reminder that leishmaniasis can be presented in viscerous, cutaneous, and mucocutaneous forms, being the cutaneous leishmaniasis the most common form, and they are transmitted by the sandflies. And then I've been reminded to think about GPA, which is ANCA-associated vasculitis, one of them. And there is multi-system involvement, including the upper respiratory tract, including chronic sinusitis, endotitis media, mastoiditis, and perforation of nasal septum. But also the skin could be affected with palpebral, for example. And we saw that this patient had increased ferritin with low transferrin saturation, and we thought about anemia of chronic disease. It's actually can be seen in autoimmune diseases, but also cancer and infection. And finally, we talked about hepatitis C. We usually don't tend to think about it, but it actually has several skin manifestations, including cryo, with this triad of palpable purple, weakness and arthralgia, but also lesion planus necrotizing vasculitis, and also PCT. So thank you, everyone. I hope everyone had a good time, and I hope to see everyone tomorrow.
Thanks, everybody. This was so fun as always for me. Thank you, Joanne. Thanks, Gabriel. Thank you, Rafa.
Thank you, guys.
Sweet case, Rafael.
Sweet case. Bye, everyone.